good afternoon, everyone, and thanks so much for your patience. I know that there's always back-to-back meetings, so we just wanted to give folks a few minutes to dial in. And we also recognize that there is an NHSN training at this same exact time, so we appreciate you being here for another week of the Superior Health Roundtable discussion. So with that, my name is Kelsey Ostergren, and I am a Quality Improvement Advisor with Superior Health. And as always, I am joined by Kim and Jerry, my partners in crime for this session, as well as our presenter today, Gray, who's one of our analysts here. And you might remember him. He's presented on this call for us in the past, so we're really glad to have him back as well. And then last but certainly not least, oh, thanks, Gray. Last but certainly not least is Yvonne, and so she will be helping us facilitate the Q&A portion of today's call. So for those of you who are part of one of our past roundtable calls, where we discussed sort of what can the QIO do for you, where we just sort of shared some of the resources that are available to you as participants of Superior Health. We know that this was a very engaging session and there was a lot of really great discussion. So we figured we would sort of like bring this back. And today we're going to be shifting gears just a little bit and talking more specifically about the data pieces. So more to come on that, but excited to have Gray as a representative from our analytics team to kind of chat through that. And he and Kim and I will all just be kind of having an open discussion, and would just invite you to participate either via chat or feel free to unmute yourself if you want to share verbally as well. Really just kind of wanted to make this informal, but share a little bit with you about kind of how we look at data, what we do with it, and kind of what you can expect from us. Just a couple other quick housekeeping announcements. As always, we will have the slides available to you. And Jerry, thank you. Put the link in chat to those. And then at the end of the session as well, we will have an event evaluation form, and would appreciate if you could just take a couple of minutes to provide us feedback on that. All right, so before we get started, I do want to just touch a little bit on what's new with COVID boosters before I hand it over to Gray. So since we last met, or maybe it's been a couple weeks now, the up-to-date recommendations have changed. So instead of this previously being the primary vaccine +1 booster or +2 boosters, if you were in that 50 and older or immune compromised, now they're just saying we require a bivalent booster. And so, because that up-to-date status impacts so many of both the operations and compliance pieces within your nursing homes, like quarantine of residents and staff work restrictions, asymptomatic testing as another example. I think this is going to be really important for us to both understand what that definition is, so that then we can ultimately adhere to it. I think all of that said, CMS did indicate that compliance with this will be based on the current existing guidance that did not include the bivalent booster. So what this means for us is that we can consider quarantine work restrictions based on the receipt of the old booster, the monovalent booster, until we hear otherwise. So I know that, people are sort of in the infancy of getting these boosters out and, the logistics around them. So I think it's great that CMS is kind of hitting pause on this a little bit, and just, allowing us to continue with that old booster before they're going to start having any sort of citations or penalties associated with that. The last thing on this slide I do just want to call out is related to the up-to-date definition that NHSN is using. So because we are in the middle, currently right now, we're in the middle of a reporting quarter, they are not planning on changing the definition right now. So if they decide to update that definition, it would happen effective starting with Q4. And so again, if they decide to make that change, they would communicate what the change is, what the new definition is, which we would have in advance of Q4 starting. That said, it is late September now, and with Q4 starting October, hopefully that's coming soon if it will change, but more to come on that front. The next couple of slides were presented on the CDC COCA call from September 13th. I just thought these were really great visuals, so I just wanted to pull them out and put them in this slide deck so you have them as a reference. I've also hyperlinked at the bottom of each of these slides where you can find these in the slide decks on the CDC website. And they also had a recording of that call. So if you missed that call on September 13th, using the links at the bottom of this slide, you can go back, and they do have the full session recording posted, so you can watch that if you're interested. So just real briefly, on the left side of this slide is the previous recommendations, which were sort of done in this dose counting way. So you had 2 doses in your primary series and then 1 booster, or again, the 2 boosters if you were over 50. But now sort of this updated guidance you can see on the right here, they are just strictly looking at the primary doses plus receipt of that bivalent booster. So I know that this can get kind of hairy if you're like somewhere in the midst of this, but really I try to look at this as if you've never been vaccinated, you haven't done any of this, this is now the updated process you would follow. You'd finish your primary series and get your bivalent boosters. And so again, just to sort of reiterate, I think the important thing here to note is that the bivalent booster is recommended for everybody, regardless of the number of previous vaccines or previous booster doses, as long as that last vaccine dose was at least 2 months ago. So again, this is what we saw in the last slide. These are just the updated recommendations here for the group of people who are not moderately or severely immune compromised. And again, just sort of calling attention to this arrow here in the middle, at least 2 months between the completion of your primary vaccine series and the administration of a bivalent booster. And then again, this is the vaccine schedule for those who are moderately or severely immune compromised. And again, the 2 months you'll see there listed is the time frame between when the last dose of the vaccine series was administered until you are eligible to receive that bivalent booster dose. So I know that's kind of a crash course. I just wanted to talk through that a little bit and just kind of draw attention to it, since I know that this is kind of new and changing and different and sort of swirling out there. I thought these slides did a really nice job just sort of condensing it down into something a little more digestible and easy to understand. So hopefully that helps. Feel free to download this slide deck and print these off, hang them up, whatever you got to do. And I would also encourage you to go back and watch that CDC COCA call if you have more questions, because it was a jam-packed hour of content. So with that, I am curious if you can just drop in the chat if your facility has already been administering the bivalent booster at this point. So if you can just put a yes or a no, or it's coming soon, or we have a date planned, that would be really helpful just for us to kind of see where we're at. And this will probably vary depending on what state you're in as well. So Vicky said October 10th. All right, right around the corner. All right, well, we'll give folks just a minute here and then we can move on. Coming soon. All right, thanks, Rita. All right, so it's definitely on the horizon. Scheduled for October 11th. Great, so kind of like early to mid-October is kind of what we're seeing here. That's awesome. Well, if you need any support in the meantime, please don't hesitate to reach out, and hopefully these slides will be helpful as you're having conversations with staff, residents, families, etc. So with that, we will move on to our formal part of the presentation today. As I sort of alluded to in my intro, these are some of the things that we're going to cover and just talk a little bit more about where Superior Health gets the data that we get, how we look at the data, the kind of accuracy and validation checks we're doing on it, how we use that data to drive improvement, and then any strategies for support. So the first question that we have here is, what data sources does Superior Health use? So Gray, at this point, I'm going to kick it over to you to talk a little bit about the data sources that we use and sort of the relevance or importance of this data for those on the line today.
So we use CDM, or the chronic disease management, the CMS, the Medicare data, as well as nursing home reported data, clinic reported data, anything that's available publicly. We would also use census data, for example. But it really does depend on what's available publicly and what we can report per the government's regulations and how many numbers are around per region or area.
Thanks, Gray. And I also know that, part of the data that we look at on a fairly regular basis is coming through NHSN, which I know we've talked about on this call in the past as we've talked through troubleshooting and, some other sort of odds and ends. Do you want to touch a little bit on sort of how that works and, sort of the logistics behind the scene there?
Yeah, so we do have a third party through Medicare that cleans the data and confirms and verifies everything is recorded or not and whether it's correct or not before they hand it over to us. And if it's not too large, the data set itself, like there's not too many things that they're counting or too many locations for us to be able to manage on our own in a spreadsheet, for example, then we have to access it through an online portal. But if we are able to download it and look at it in a manageable spreadsheet, we can pull some information and use it either in Excel format or independently of reporting software, or use, our own software on our computers. Basically, anything that's not cloud-based. If it's manageable through an Excel file or something you can email to somebody, then we would be able to do a little bit more with it. But if it's something that we can only access through the cloud that is controlled outside of, being able to manually type something in, then we can only report certain types of data formats and answer so many questions. So that's always something to keep in mind, those limitations, the scopes, the parameters, how complex or simple the numbers you're looking at are, and what kinds of questions can you really answer or not, and why.
Now, Gray, did you say you do, or we do here at Superior Health, we use the MDS data from the nursing homes, is that correct? And if so,
Yes.
how do we use that data? In what areas do we pull? What kind of data do we use from them?
So that would be something like if you're looking at different medical claims, or if you want to see how many residents in a nursing home, for example, have a certain condition, or how many times someone went to the doctor, the hospital, emergency room, questions like that.
So you talked a little bit about, I might be jumping the gun here, but just came to my mind, Gray. And you talked about like cleaning data, and that's something that's already done. But I think it's even more than that, though. And what I'm thinking is we have to ensure on the nursing home side that the information that we're putting into, let's just say, the MDS is accurate, right? That it's, but we're putting the right stuff in there. Do you have any suggestions on what would be good strategies to make sure that your data is accurate and missing data, not having missing data also?
Yeah, always have 2 or 3 people who are considered responsible for collecting the information at least. And especially for reporting data, giving yourself those double, triple checks. We're all human. And if you're used to looking at very fine details, especially all day, or if you are just having a day when you're tired, or even if you're not, if you look away, you can make very big mistakes by accident. It's very simple. So when I say cleaning the data on my end, that would mean looking through, adding things up, doing double checks across time and across resources, so comparing census data to nursing home reports, or comparing one week to the next to see if there's any sort of pattern. Or for example, if a nursing home generally reports one resident has a booster, and then all of a sudden they have 996, I'm going to question that. It's going to look a little obvious that maybe they either had a very big change in capacity or administration or policy, or they made a mistake. So I would have to look into that or call or ask. But if people who are doing that on their end, if they can just make sure to do a double, triple check, then that will prevent a lot of questions and a lot of circles and a lot of communication issues, or possibly, needing to be looked into by DVAC or Medicare on the government side.
Yeah, I'm thinking too, Gray, that training, I think consistent training, and I mean, the participants out there too, the nursing home administrators, DONs, if you don't have consistent training for, let's say, your CNAs with their ADL documentation, or maybe the nurses aren't all on the same page with pressure injury, right? So when they're documenting their data into their nursing notes, that's going to skew the MDS. Or when that CNA does not understand extensive versus limited, that's going to skew your quality measures, or audits for your RAC audit or some other advantage care audit or what have you.
Exactly.
Yeah.
There's countless ways we can interpret things. And keeping in mind that while we say data, people think numbers, they think statistics, they think it's very black and white. It's very much fluid. It can also include anecdotes. There's just different limitations or different questions you can answer with different types of information. And so there is a data dictionary online along with those trainings to attend, like ResDec trainings, that can help people understand why they're being asked questions, what exactly the meaning behind those questions, where they're reported to, and how they'll follow through. And the great thing is, we here at Superior Health have people like you, Kim and Kelsey, and Yvonne and everybody to answer questions and to help out with improvement if you are being told your scores are low and you don't quite understand why, or you don't know what to do and you need help with improving.
Yeah, and I think, Gray, to that end too, just thinking about the missing or inaccurate data, right? Like, so we know that, there's a lot of expectations and requirements and regulations, data and otherwise, that our homes and our administrative teams that they're responsible for, right? And so, yes, data is part of that. And with the data entry, some weeks get missed, or there's turnover, or you get locked out of NHSN, or your NHSN person has left, right? So, there's sort of a lot of logistics there in terms of how do you actually get that data. It gets great in concept, right? But like, how do you actually get that data in? And so, from our standpoint, and Gray, you alluded to this a little bit, but in the event that maybe you fat fingered a key and you type 99 instead of 9, obviously NHSN does a check to make sure that that's valid, but it's not really until Gray and the analytics team get their hands on it and can look and sift through it and sort of do some of that trending and think about, okay, is this reasonable? Is this change something that we might expect or could be plausible? Or do we think this is something that's sort of a question mark, maybe like an item of follow-up? So I do think, while there are requirements of the homes, which, you guys have all been fantastic with abiding by and doing the work that you need to do, our team is sort of here as like a double check, just to make sure that, the data that's being entered is correct and is accurate to the best of your knowledge and abilities, and sort of provide that stopgap for education if there's gaps there that have been identified.
And even if you are collecting it and it's handwritten, the number of people that it goes through, it can become like telephone, right? So maybe that 1 is a 7, or maybe that 7 is a 1, maybe that 3 is a 5. Those kinds of things can come into play. And then hopefully you would have somewhere electronic, and it is pretty much required at this point to have an electronic way to communicate, and make sure that more than one person, or it's in a shared drive or shared folder that multiple people can access, but still protect your spreadsheets, protect the information. The software has capability to do that. And if you need help with that, there's online tutorials as well, or I would hope you can ask a coworker who's a little bit more savvy or less savvy, who knows, make sure everybody's on the same page, and that can go on with trainings. And if you have a question or you want to make a correction, I would say there's nothing wrong with letting us know. And having a standard place where you have everything reported can help with those double checking and making sure that what is being seen on our end is what you're reporting, because maybe there's an issue with that too. Things happen.
Yeah, and so Gray, on that note too, I wonder if we can just talk a little bit about sort of our processes for validating. So whether it's NHSN or MDS, like once the analytics team, so once your team gets that information, like what kinds of things are you looking at? How are you assessing the files? How are you pulling out things that might not be correct or might require follow-up or are definitely not correct? Can you talk a little bit about that process from sort of the back end?
Yeah, it really does depend on the measure. And this has to do more with measures in terms of what I was talking about before with the numbers data. It's a little bit, when you come to words and stories and qualitative data, it's a lot more fluid, and it's a lot more about whether someone's story is independent and makes sense. But with data, you take that mindset and you kind of put it into little categories, and you'll pick up on patterns with those numbers or with those diagnoses codes. And there are high-level statistics to interpret or to predict whether something does make sense. But if you don't want to go into the time, or if you just don't have the software, because some places don't have software like that, Excel again has some pretty simple formulas. But of course, you have to understand how to interpret those, which is why it's really important to understand the difference between reading something or digesting something and understanding what it might mean or the limitations and the values. And that's where analytics comes in. So if I look at something fresh, like what we're talking about, I will automatically just see how many rows there are or how many locations there are. And I'll see how many things were reported overall in the spreadsheet. And if something is missing, where the things tend to be missing. So if someone was reporting a bunch of high blood pressure or low blood pressure or just blood pressure in general, I would go in to see the range of values that are reported, whether it looks like maybe the diastolic was reported instead of the systolic somewhere or vice versa. That's a simple explanation for something everybody can kind of grasp. But the more abstract it becomes, the more difficult it becomes, and the larger the number of variables and of locations that are reporting, the more those high-level statistics of like Cronbach's alpha, which is to see whether something does make sense in terms of a trend, a line, all those calculus things that no one wants to hear about, but I love. That's what we do. So it can be really helpful. Maybe you aren't sure. Maybe you collect for a lot of different locations for your health system, and you have questions about that. That is something you can request from us as well, that we do, if you don't have access to it or if you're curious. I hope that answers the question at least a little bit, but feel free to let me know if there's anything else you wanted me to touch on.
Yeah, I think that's helpful, Gray, just in terms of, understanding sort of the A to Z, right? So the nursing homes are entering the data, whatever, through whatever mechanism, whether that's NHSN, whether that's MDS, whether it's, something else. And then sort of that connection of Superior Health pulls that data and looks at it, and sort of does these accuracy or validation tracks. And to your point, it is much more complicated than just sort of looking to see, yes, in fact, the data was submitted. Now, certainly that is part of what you're looking at, but I think
it's a big part too.
Yeah. And I think the more challenging thing is the sort of like, is this realistic? Is this possible? Could we expect to see this? Which takes a little bit more analytical power, human brain power, to try to sort of make those connections.
And it might not be so difficult. It might just be time, and like with any relationship, right? We all have a set of skills or know that we have limitations in our capacities. And it's through history and it's through getting to know someone and just being there and observing that we can really get to know specifics. So sometimes it really, the value of analytics is just that, oh yeah, I've been looking at this measure forever, so I know when it looks off, but I don't really exactly know why. You might hear that sometimes, or you might hear me say, oh, I really need to familiarize myself with this before I can have an answer. It's because we can't just speculate. We need to be able to say that we don't know, and that what we do in between then is often just scanning and looking and trying to figure out what the best way to communicate what we're seeing is. I think that might be more helpful.
Yeah, and so I think to that piece about how do we communicate what those number is, that sort of leads us into like sort of the actual analytics of this, right? So like we now have done sort of our data cleaning, we've done validation, we made sure that any missing records or fields have been updated, maybe rectified any errors in entry, whether it's higher or lower, or things that were put in the wrong spot. So we've gone through that point. We now have a clean data set. So talk to us and sort of explain the process of like the actual analytics. So like what kinds of reports does Superior Health build, or what kind, what can we look at? Like what comes out of that?
Yeah, so the nice thing, I've gotten to be such a data nerd over time. So you can do, I mean, again, this depends on how it's reported and what we're trying to say. So if you want to see how many people have gotten vaccinated over a certain period of time, that can be a simple cumulative count, right? In theory. But if you take into account, like we were talking about, the high turnover or residents moving in and out, or policy changes, things like that, it goes from being a relatively simple idea in theory to being very complex and very difficult. And so having someone that is already familiar with how those numbers can look and with what needs to be reported and where that space needs to be filled, if it's a simple matter of, oh, I thought you meant one person per week was boosted, but actually this variable is asking how many people were boosted cumulatively or adding to it every week. You would start to go from saying, see, for example, I'm not saying this is any coincidence, in truth is sorry. So if it's a coincidence, if any of this sounds true to anybody. So you might go from having like a 1% improvement rate every week to having a 30%, 40%, 50% increasing over time, because maybe someone didn't understand the difference between one person being boosted versus everyone over time being boosted. It can be as simple as that. Or like I was using before with the blood pressure example, if the average rate is one blood pressure, but the average is for the whole nursing home, it wouldn't make sense to look at an average if there's hundreds of people that have many different blood pressures that range all over. You wouldn't really be able to gauge the health of someone's heart based on a blood pressure measure that's an average, because every single body is different. So you might want to also look at how many people are diagnosed instead, which is why we tend to use claims data, or what kinds of other conditions go into having hypertension or along with it. Is it associated with something, or does it really help cause it? Those are all very important questions to ask that do require a lot of process, thought, consulting with actual experts, biomedical experts, as well as biometric experts. And I'm only a biometrics expert, so I might be able to tell you, what a blood pressure measure is, but I won't be able to diagnose you as having hypertension or not based on blood pressure alone, if that helps.
Can I also add that for the analytics department, a lot of time the data that they analyze is data that we request. So for instance,
Exactly. Thank you, Yvonne.
For instance, if we're looking for MDS data from a certain section from your MDS. So just recently we were pulling data from the N section. So we had to go to the analytics department, request what we needed from the N section. And when they did their magic, because I can't tell you what it's called, but when they did what they were able to do, we were able to see what we needed. Now they were able to say, yes, this is the answer. We're sure this is the answer that your building has, or several buildings has given. And now it's up to us as your QIA to contact you and say, listen, we had this information pulled. There seems to be a concern here, and can we go over this with you and help you get this to where it should be? So that's with the MDS, and the same thing with the NHSN. When that information is pulled from NHSN, when we see that there is an issue somewhere, like Grace said, sometimes the numbers are high and then they may drop. We see a percentage of a 50% drop in a month. We know that either you had a change in the person that's putting the information in, no one put the information in, someone hit the wrong, something is wrong. So you'll get a call from us saying, okay, the analytics department let us know that there's an issue here. And so we're here to try and help you figure out what that problem is.
Yeah, that's perfect, Yvonne. I think you took us right into is that the next slide, Kelsey?
Right?
About what we do as the TIAs. I'm having a stroke apparently.
The QIA.
I'll jump ahead here. Yeah.
Right.
Well, can I mention something before we move on real quick that Yvonne made me think of?
Sure.
Thank you. So along with requesting the data, we also have to know the source. So sometimes we'll get data requests and we'll look at each other and say, do you know how to measure that? Do you know what we get, or where we would look to see about, remote patient data for online health classes for this particular toolkit? Nope. So we would need to be able to have access to a data source, or we need to be told, what kinds of examples are you looking for in order to send a request to us as well. So we get a lot of those kinds of things too. That might be interesting for nursing homes or health facilities to think about. And then again, another question to ask your QIA. So I think that helps move into the next one.
Yeah, we mean as a QIA, a quality improvement advisor, Yvonne gave two excellent examples of how we do use your data. And I just wanted to also fill in with, that's what I start with. That's what prompts me to even make my phone call from you, is what I'm getting from Gray. That's what I'm getting from the analysts. And I do my homework first, come prepared when I get on the phone with you to say, this is my hypothesis. This is what I think may be going on. And I'll talk with you about that. We'll get down to what the root cause really is. And hopefully it's just a keystroke error. Those are the ones I love. Those are the ones that I said, nice talking with you, and anything else I could do for you. But a lot of times it's even more than that. And we get down to other root causes of possibly just actually not understanding NHSN directions, or even more so is when actually the data is correct. And that opens up a whole nother can of worms, because now we need to figure out why is your, I don't know, your vaccination rates not where they are. And we'll go through a series of questions, figure out if you have a gap in your system or whatever it is, and then provide technical assistance, resources, whatever needed to help you succeed.
And it's a preventive way. We're not punitive at this point. And we definitely want to prevent any issues with compliance and make sure that we're doing everything we can to make sure that everyone has the best opportunity possible to improve and to stay compliant, because we want things to go well. I think that's what people might forget too, hearing from everybody.
Yeah, I think that's a great point, Gray, just because, yes, we look at this data, and yes, we have all the same data that, your regulatory bodies are looking at, that you're federally or, at the state level that you're required to report. But our goal is sort of to be like almost the intermediary. So we want to catch this stuff before the state does or before CMS does. And we want to be that friendly face that, like, when you see us, your heart doesn't sink. It's like, oh no, they're here to help us, because that really is our goal. We want to make sure that we're catching these things to help you and to make sure that you're in compliance and that this isn't, tied to any payment. And if it is, that the data that's entered is accurate. And then to Kim's other point, if it is accurate and it's an outlier and potentially not a great way, how do we dig through that? And it's a tough conversation, but again, with that sort of keeping in the back of your mind that we're here to be supportive of you, and using this data to drive improvement, right? Like, we want to know if these are areas you're struggling with, we want to come alongside you and see how we can support you in this. And with all of the responsibilities that each of you and your teams and all of your staff have on your plate, quality improvement probably has fallen down that list a little bit in the midst of a pandemic. So, our goal is to really sort of be that voice and to help you do some of this work. We're happy to do whatever it takes, but, at the end of the day, we're not in your building. We don't know your team. So that's where we rely on you sort of as our point of contact to sort of take that baton and carry that work forward. But I just sort of wanted to reiterate the fact that we, again, are not punitive. We are here to be helpful, whether that's, correcting data or identifying trends and then sort of working with you to do something about those trends.
And just to add to what Kelsey is saying, one of the positive things that's come out of us listening to you and hearing what you need is frontline forces. So after seeing at the beginning of COVID that there was not really time for your staff development nurse to really deal with frontline issues with the staff, but the training was still needed. After we did the ICARs, and some of them were the targeted response ICARs, some of them were the regular ICARs, we were able to see that training was lacking. And I know it's off the beaten path from this, but it's just to let you know how we were able to put something in place to help you because of you letting us know what you need. But first, us actually getting information showing that there was an issue, because that was the purpose of us contacting you for the ICAR at that time, because there was something going on at that time.
And Yvonne, I think that's a great example, just of sort of a very tangible way that Superior Health looks at data, identifies opportunities, and has these conversations with you. So when you get a call from one of us at Superior Health, it's meant to just sort of understand what's going on, ask questions, explore kind of what you're dealing with, and offer support, whether that's immediate support of how can we help you get your data in this week or rectify these data errors, to some of those more longer term pieces, as Yvonne alluded to in Frontline Forces, of, okay, we recognize you're struggling with this. You don't have the capacity to do that. Is this something that Superior Health can take on for you and give it back to you as a way that you can then, meet all of your requirements? In this instance, the staff training piece. And, this call is another mechanism that we solicit your feedback. And we ask, are these calls relevant? Do you want something different? We're always open to that feedback because we recognize your time is precious and we want to make the best use of it. So I think, all of the folks that continue to show up to this call and answer all of the other calls from our staff and join a variety of different programs. I mean, all of this really is sort of with the goal to be helpful and, empower you to do quality improvement within your own facilities. But we do want to be a resource. So if there are things you're struggling with, is this the right forum for it? If not, what is? Because we will figure out how to do it. Because again, we recognize you guys are all super busy. And if we can take one thing off your plate, we are more than happy to do that. And Kim, thank you. I see Kim just posted in the chat a link to our Frontline Forces training module. So if you haven't had a chance to take a look at those, you can click that link and see all of the ones that we have developed thus far. And there are more in the works. So keep checking back and we'll continue to promote those through our email communications as they're released as well, so that if and when something new has been posted.
So I do have, I have my favorite data and you're like, how could you have a favorite data? My favorite data is the data that I get from Gray. And it says that the nursing home I worked with has just went from a 75% booster rate for their residents. And in the last 3 weeks, we've been working together and they're up to 95. That's the phone call I like to make and the data that I like to share with the nursing homes that I work with. And if not, though, that's okay. We'll just go right back, change something up and keep going. We'll figure it out.
Yeah, it won't be the same every week, but we're hoping to maintain and aim for that date.
And can I just mention, as your Quinn or QIA, when we work with you, sometimes there's very little improvements that's made, but there are improvements. CMS notices that. And so maybe you're not the facility that has a 90%, you're the facility that has 70%, but you went from 0%. So those type of increments make a difference. And then when you form a relationship with your QIA, and I do understand we call you for many of things, but sometimes you have one QIA that you just really connect with, that you're able to call and talk to, and those things are communicated and documented. And then when CMS comes to us on a bigger scale and ask about your facility, we're able to show each level of what you've done with us, the documentation, how we've worked with you, how you've improved, and they see the growth. So it really makes a difference when you work with your QIA, who's able to, like Kelsey said, we'll create it if we need to. We're going to work with you and get what you need done.
And on the flip side of that too, Yvonne, so beyond us as the QIO saying to CMS, look at all the homes that we've touched, I think the same goes for you. When you have a state surveyor in your building, you can pull out the ICAR assessment and say, I've been working with my QIO. They did this ICAR assessment. We've been working on a quality improvement project. You can show them the work you've done. You can show them that data. And so that's helping you too, right? And that's really our ultimate goal. So I'm hopeful that this sort of conversation we've been having around data has been helpful. I know, Gray and I are data people, so we live in this world, we thrive here, but I know that it can be sort of nebulous and scary and confusing. There are so many data sources and requirements for what you need to submit, where you need to submit it, when it's due. I mean, the list is endless. So, I think at Superior Health, we're really grateful for Gray and the rest of the analytics team for the work that they do to just like pull everything out of cyberspace and sort of condense it into one place. And just make it something that's usable and digestible for us as quality improvement advisors to then have those conversations with you about, what's going on, what's happening, how can we support you?
And also making it make sense. Kim and I both have MDS background. And so when we have data pulled in the MDS, where it's something related to MDS, a lot of times we'll both start calculating, saying, this does not make sense. Why is this? And then Gray and the analytics team will say, well, that's what it is. You all need to do your part to figure out why it's that, but that's the answer. So when we see that and we start looking at each section and talking about the sections, we'll come up, most of the time we'll come up, it has to be this or that. So we know what questions we need to talk to you about because we have the background to know what the issue could possibly be.
For the audience, have you ever had, like maybe you're doing the work, right? It's being done, everything is excellent, but your numbers aren't showing improvement on, like, let's say your quality measures. When it boiled down to it and you went down to the root cause, did you find it was documentation? Has that happened to the team that we have here today? Well, maybe not for you, but I will tell you, Yeah, sometimes. Thanks, Rita. Yeah, I had a couple of projects where, like, for example, the QM, the quality, which one is the ability to improve independence worsened, and it was all about CNA documentation, where the part of the exclusion on the MDS is you can exclude all those people that are dependent in locomotion. But if your CNA staff isn't choosing total for that 7-day look period, and just one time they chose 2-person assist or what have you, your numbers are all messed up. So, I mean, basically, to make a long story short, it's just making sure that, you know, do you know your, as far as MDS data and what you're putting in, do you know what the exclusions are? Is somebody following that? Is somebody auditing what your CNAs are doing, so that you know that the exclusions are correct when you're entering this data? I just happen to have that happen in quite a few MDS documentation rules that we were doing wrong. Once we got education standardized, we had people doing audits. Our QMs went from here to here, and it was just awesome to know that we were actually doing the work correctly. We just weren't documenting correctly.
And, you know, that's a really good point too, because I have had a very unusual career for an epidemiologist and healthcare analyst. I've worked in hospitals, I've worked in nursing homes. I'm not a provider. I have gotten trained and I was an assistant, and I did not do well. It was hard. So I now have a completely different attitude, but because of I don't want to call them failures, opportunities that I gave myself to learn a lot very quickly about things I'm not good at, I have a much better perspective. So when I was doing data entry at those jobs, I was told just put in what the last person put, or no one's going to have more than 25 breaths. If you put this, then the nurse will come and they'll question you. If you don't put that, if you put lower than that. And I was like, this is an analyst nightmare. This is what I don't want to see. But it's not that it wasn't correct. It's not that the person wasn't alive, wasn't breathing, wasn't doing those things. It's just that we want to be able to look for ways to prevent future issues that could happen. And we also want to see if maybe there's something happening where we missed. And so that can turn into trends, that can turn into lines that, people, I remember when I was helping out with COVID-19 testing in Detroit, and I pointed out to them that certain testing type machines only had a specific level of reliability up to 94%. And they said, well, it's 95%. I heard them say to the International Coalition. And I was like, no, 94. And they told me, what's the difference? Who cares? Sit down, and then they, of course, were like, oh, we meant, and then they rephrased it differently, but it wasn't that they didn't want to be compliant. It was that it wasn't the right time, or it wasn't the right way to say it. And what I should have done is just waited until after, because nothing had been written down. It wasn't a formal, I just wanted to prevent issues. So that's something that I've learned in my career, is that sometimes it is how you explain things. So that's what data analysts and QIAs can help you with, is making those reports, advocating for yourself, advocating for your facility, advocating for your nurses and for your administration, and just seeing what kinds of tool sets we can help you with to prevent issues and to continue having none.
Which leads me into this next question. So knowing that Superior Health has the analysts and they're able to ensure the accuracy of data that we pull from your facility, what type of assistance especially knowing that we're able to look at your NHSM, we're able to look at your MDS, we're able to look at claims data, what type of assistance do you think would be best needed for your particular facility?
Well, I think that's a great question. First of all, it's refreshing. I don't often get that question.
Oh no, it's just for you, Gray. I'm sorry.
Not for me, for the nursing home people.
Yeah.
See? And I would hope that they get this question way more than I do. Sorry.
So Rita asked, how can we see our data to know what issues we have? So we're looking at the same data that you're actually looking at. So we're looking at, let's say when your MDS nurse sends in, she's sending in an OBRA or Medicare, and she sends that in and she gets the report back that says, you sent in whatever and it's different from what it was last month. Now, usually before that report ever comes back, you have some type of scrubber in your system that tells them something is wrong before they click to go ahead and send it to the state. So, but once they hit send it to the state, that data that's sent to the state, that's what we're able to see as well. And if they didn't correct it, it's flagging that something is different. So when you look at your CASPER report, when you look at your NHSN, well, you may not, you can see your NHSN data and see that it's different if you go to, what is that, Kim? NHSN.data.gov.
Yeah, you can see all the data that is in NHSN at data.cms.gov, but right. You are also able to, on the NHSN level, to run your own reports.
Right.
We have a nice little cheat sheet on running reports too, if we that we can send if anyone would like that.
Right. So what I'm saying is we're not looking at anything different from what you already have.
And Gray, is there anything additional you would add to that? Are there other reports that folks can have access to that Superior Health sort of puts out?
Yeah, that goes along with making a data request and staying in communication with your quality improvement advisors, because they'll be able to explain or remind you or update you. And again, making sure that there's not just one person who's in charge of collecting, storing, reporting, things like that, because that way you can stay in communication with your own facility as well.
Absolutely. So, and I think on that note, if you don't have somebody from Superior Health that's, you know, your buddy or that's constantly reaching out to you or that you're working with, feel free to reach out to any one of us, Kim, Yvonne, Jerry, myself. I know there's others on the line as well. We're more than happy to help either take that on ourselves or connect you with somebody who might know the answer to that. So feel free to shoot any one of us a message here on the Zoom chat, and we're happy to connect with you offline as well. All right, and so I see that Jerry has posted the link in chat for the evaluation for our session today. So thank you, Jerry, for doing that. And we just encourage folks, if you could click on that and just take a few moments to give us your thoughts, we would really appreciate that. And with just a couple minutes we have remaining, I just wanted to put in a plug for a few of our upcoming sessions. So next week, we will be joined actually by one of your peers who will be sharing a little bit about the leadership and infection prevention, that relationship and dynamic in her organization. And then the following week, October 5th, Gray and Yvonne, you'll be back again to do another session for us and just talking a little bit more about some of the sort of history and the myths that, you know, are certainly part of the ongoing resistance to vaccinating. So would encourage you to join those if you're able. And thank you, Kim, Yvonne, Jerry, all for putting your emails in the chat. So for nursing homes on the line, please feel free to reach out to anyone and we can certainly answer any questions you have. I do see, sorry, Kim, I do see one comment here from Kevin. So he's saying, due to the size of the facility, many times we get the insufficient data or sample size too small to calculate, which is really frustrating. Gray, any feedback on that comment?
So Kevin, I'm a little confused at what you mean to calculate percentages and benchmarks, because does that mean you're not having anything? Because hopefully you would have at least one staff member or one resident at any given time. So you'd be able to calculate percentages and benchmarks, even if you have one. That's something. Does that help? I hope
when
it
we
does.
try to run the reports, when we download them, we'll get a lot of just.
Oh, so you
empty-
download the reports from the website.
Right.
Okay, so I would encourage you to use the internal data that you are reporting to create those percentages of benchmarks for your own internal reports, or consult with your QIA. I'm not sure if I am able to do anything one-on-one, so I would have to ask CMS for permission to do one-on-one. But that's why our QIAs are there. So definitely reach out to somebody and then find out, who is the reporting person if it's not you. And then find out how to get access to that if you don't have it already. If you do have access to it, feel free to do those percentages and look at that.
Kevin, are you speaking of the NHSN report from the site that Kim stated?
Yeah, not so much with the NHSN, all the, like any of the other quality measure reports.
From your Casper?
I'm sorry, what was that?
From your Casper report?
Right, exactly. Mhm.
Okay, so you contact one of us so that we can
Okay,
find out what.
thank you all.
Yeah,
Thank you,
please.
Kelsey.
Yeah,
Thank you for your question too, Kevin.
Absolutely. Well, this has been a great discussion today. So thank you all for joining us and for kind of listening to us chat about data. Hopefully you've learned something and taken something away. The slides and evaluation are in chat. And we will close our call for today and see you all next week. Take care.